Hello guys, welcome to ENT Mastery Course 2.0 in association with MEDEX and World ENT Care. I'm Dr. Shyam Kalyan and today we are going to talk about functional brain imaging. The two main important imaging topics under this are functional MRI and PET scan. So we shall be discussing what functional brain imaging is with special attention to functional MRI and PET scan. In your theory exam point of view, these are very oft repeated questions. Functional MRI, its principles and applications in ENT. Similarly, PET scans, the radiotracers, the principle and its applications in ENT. Next, in your DNB OSCE exam, frequently they keep reports or the pictures of functional MRI and PET scan and ask you to differentiate between these, which is which, identify which is which. And trust me guys, during exams, both these pictures look exactly similar. So, going to functional brain imaging, it includes any technique by which physiological changes accompanying brain activity can be followed. So a normal MRI or a normal CT scan is a snapshot of the anatomy or the pathology at that time. It does not show anything about the physiological changes accompanying brain activity. Whereas functional brain imaging includes any technique by which physiological changes accompanying brain activity can be followed. So we have 5 tests under this thing: electroencephalogram EEG, magnetoencephalogram MEG, positron emission tomography scan, the PET scan, functional magnetic resonance imaging fMRI, and single photon emission CT scan, SPECT scan. Let's see a few details about each of these. Electroencephalogram and magnetoencephalogram monitor neuronal depolarization. Electroencephalogram and magnetoencephalogram monitor neuronal depolarization. So they have 10 to 20 milliseconds, the most excellent temporal resolution. 10 to 100 milliseconds, the best temporal resolution. These show events in real time, but they have a very poor spatial resolution. Positron emission tomography, it has long acquisition times. You will read about it. You need to give a radio tracer and the radio tracer needs to be concentrated at certain areas of interest. So that takes some time, long acquisition times, and the temporal resolution is tens of seconds. It has a moderately high spatial resolution, 5 to 15 millimeters. It measures energy requiring metabolic changes in the body. So positron emission tomography has tens of seconds for temporal resolution, a moderately high spatial resolution of 5 to 15 seconds, and it measures energy requiring metabolic changes. Moving to functional MRI, it provides information on increases on blood flow following neuronal activation. Increases in blood flow following neuronal activation. It has a higher spatial resolution, 1 to 10 millimeter, and a good temporal resolution, few seconds. The temporal resolution is limited by hemodynamic changes. You would see that in bold MRI. But the temporal resolution is better than PET scan. You must remember, in temporal and spatial resolution, the lesser the value, the better it is. In the case of temporal resolution, it means like after you give the tracer or the radioactive agent or the contrast, when does the changes occur and when it can be detected in the scan. That's the temporal resolution. The sooner you detect, the lesser the value of temporal resolution, the better the scan for you. Similarly, spatial resolution means something like your, the distance, the minimal distance that can be picked up. So the lesser the spatial resolution, the better the actual, the results. Moving to the last thing, single photon emission CT scan. It has a spatial resolution of 10 millimeter or 1 centimeter, which is a little less than the PET scan. So now we are going to deal with functional MRI and PET scan in detail in this instructional video. Moving to functional MRI, we shall be discussing it under Introduction, Principles, Advantages, Disadvantages, Applications, and a special case of perfusion functional MRI. Functional MRI provides information on the increases in blood flow following neuronal activation. There is a depolarization and neuronal activation. Subsequent to it, there is increase in blood flow. fMRI detects this increase in blood flow. fMRI creates a series of images that capture blood oxygen level in different parts of brain. It creates a series of images which capture blood oxygen level in the brain. It's a technological variant of MRI to allow doctors and researchers to watch the brain in action. Yes, guys, this is the term, to watch the brain in action. As we discuss the principle, the most common functional MRI principle is the blood oxygen dependent, level dependent contrast. So the bold MRI is the most commonly used functional MRI. In this, we use hemoglobin. It's an endogenous contrast. You don't have to provide anything from outside or intravenously. It is there inside your body. When the hemoglobin is oxygenated, it is diamagnetic. It repels the magnetic field. Whereas when it is deoxygenated, it is paramagnetic. It absorbs magnetic field and reduces repulsion. So when there is a change in the oxygenation of the hemoglobin, like when it is getting deoxygenated, the changes in local distortion of magnetic field applied to it. So when the hemoglobin gets deoxygenated from oxygenated, it changes from diamagnetic to paramagnetic. It initially was repelling the magnetic field, now it will absorb the magnetic field. So if you apply an external magnetic field to this, like what happens in magnetic resonance imaging, there is a change in the local distortion. And this change is measured by functional MRI. It has a spatial resolution of 1 to 10 millimeter, slightly better than PET scan. The temporal resolution, the time lag, is determined by the hemodynamic changes accompanying neuronal activity. So we have seen that you have a depolarization, you have a neuronal activation. Next, it needs to change the blood oxygenation level. Only then it will be measured by fMRI. So this hemodynamic changes accompanying neuronal activity causes the time lag. It is in terms of few seconds, 2 to 6 seconds. The results are interpreted in terms of synaptic activity rather than neuronal firing. This is a more accurate thing. Synaptic activity is more accurate than neuronal firing. So you have seen what blood oxygenation level dependent MRI is. This is the most common fMRI. It is an endogenous contrast. Oxygenated hemoglobin and deoxygenated hemoglobin have different magnetic field properties. One causes attraction, the other causes repulsion. This change is measured by fMRI. Now when you see the advantages of fMRI, it is non-invasive, there is no radiation. Always remember that MRI has no radiation, but CT always has. This has no intravenous contrast. Blood oxygenation level dependent is an endogenous contrast. It has better spatial resolution than PET scan and electroencephalography. It defines interacting regions of brain. Whereas when you see the disadvantages, there is a temporal resolution in terms of few seconds. It is poor. It is dependent on the hemodynamics. See, this temporal resolution is poor in relation to electroencephalography and magnetoencephalography. The temporal resolution is not poor in relation to PET scan. That you must remember. But compared to your EEG or MEG, this resolution is poor. Second, the main important problem that is produced by fMRI is the loud sound produced by the scanner. This can cause acoustic trauma. This can confound in studies of audition. Also, when you check frontal and orbital areas, there is significant signal dropout or spatial distortion. Also, the cerebral blood flow is an indirect measure of activity. Small movement of artifacts or brain can lead to poor images in fMRI. So the 5 disadvantages are: temporal resolution is in terms of seconds, dependent on hemodynamics. A loud noise is produced which can confound results and also cause trauma. There is significant dropout in signal and spatial distortion in frontal and orbital areas. Cerebral blood flow is only an indirect marker of activity. Small movements of brain can lead to poor images. Whereas the advantages were it's non-invasive, no radiation, no IV contrast, better spatial resolution than PET scan, defines interacting regions of brain. When we move to applications in ear, nose, throat, you have 5 important applications. 1. It images normal brain auditory system. Second, it defines functional relations between brain regions. Third, it images plasticity. Fourth, it images drug responses. And fifth, it images normal brain olfactory system. First, imaging normal brain auditory system. fMRI has provided us immense information on the organization of auditory cortex, on the tonotropic representations in the auditory cortex. It has shown to us that left hemispheric dominance is present for pure tone processing. It has also shown us that left hemispheric dominance is present in language and speech development. It also shows us stimulation of various intracochlear electrodes in post-op cochlear implant patients. So when it measures normal brain auditory system, it has shown us organization of auditory cortex, tonotropic representations in it, left hemispheric dominance for pure tone processing and speech and language, and it has also shown how intracochlear electrodes stimulate various areas in post-op patients. While defining functional relations between brain regions, it has defined interacting regions of brain. It has found auditory processing streams. It has helped us understand the functions of cerebellum. So it has defined interacting regions of brain, it has shown us auditory processing streams, and it has helped us understand functions of cerebellum. In imaging plasticity, it has helped us understand learning process for different frequencies of sound, reorganization of cortical representations with learning, plastic changes that occur after cochlear implantation, impact of early auditory deprivation and sign language on auditory cortex. It has helped us understand learning process for different frequencies of sound, reorganization of cortical representations with learning, plastic changes which occur after cochlear implantation surgery, and the impact of early auditory deprivation and sign language on cortex. It has also helped us finding out how drugs are responded by the body. Cholinergic responses of physostigmine are also studied. Functional MRI has also provided us immense details on olfaction, olfactory pathways, and how olfactory coding occurs. Now, this is a picture of blood oxygenation level dependent MRI. This is a sagittal section of the brain. Sagittal section of fMRI obtained while the subject passively listens to a story read to him. So the subject is passively listening to a story read to him, and this is the area in superior temporal gyrus. There is this bold oxygenation, bold activation, large orange blob. Area of blood oxygen level dependent activation, the large orange blob, has been overlaid on structural 3D volume T1 weighted sequence. This is the superior temporal gyrus, and here we have the source of this picture. Finally, we come to perfusion MRI. The principle of perfusion MRI is it measures changes in perfusion with neuronal activation. Whereas in bold MRI, we measure changes in oxygenation with neuronal activation. And we also saw that it was an indirect measure of neuronal activity. Here, we measure changes in perfusion with neuronal activation. This is a more direct measure of brain activity than bold MRI. Initially, perfusion fMRI was achieved by giving a paramagnetic MRI contrast agent. an intravenous contrast agent used to be given earlier for perfusion MRI. Now, however, we use a non-invasive technique, arterial spin tagging. Arterial spin tagging uses radiofrequency pulses from MRI system itself to transiently label flowing blood. So there's no need for exogenous contrast agent. So perfusion MRI currently uses arterial spin tagging, radiofrequency pulses from MRI system itself to transiently label flowing blood. But however, the drawbacks of perfusion MRI are it has low sensitivity, so it's used less. The applications are less. So let's just check what perfusion MRI is. It measures changes in perfusion with neuronal activation, more direct measure of brain activity. You use arterial spin tagging, uses radiofrequency pulses from MRI itself to transiently label flowing blood. It has low sensitivity. So we saw functional MRI under the headings of introduction. What is it? How do you watch the brain in action? What is a principle? BOLD. What is a spatial and temporal resolution? BOLD is an endogenous contrast. Advantages and the disadvantages. Then what are the applications in ENT? The 5 applications in ENT. And this is how a picture looks. If you get it in your DNB OSCE exam, then this is how BOLD MRI looks, functional MRI. And we saw about perfusion MRI. Next, we are moving on to PET scan. We shall be discussing this under definition, principle, PET CT integration, ENT applications, various radiotracers, non-oncological use, and disadvantages. Definition: PET scan is a nuclear medical imaging that produces three-dimensional image of functional processes in body. It identifies pathology based on altered tissue metabolism. It measures energy requiring metabolic changes. So while writing the definition for PET scan, do you need to remember? First, it is functional imaging, right? So it has to measure functional process in the body. What is the functional process that it measures? Altered tissue metabolism. What will it measure? Measure pathology. We are concerned about pathology. So it measures energy requiring metabolic changes, especially in pathological tissues. And this is based on a radiotracer. So it is a nuclear medical imaging. So how do you define? It's a nuclear medical imaging that produces 3D image of functional processes in the body. It identifies pathology based on altered tissue metabolism. It measures energy requiring metabolic changes. PET scan is nuclear medical imaging that produces 3D images of functional processes in the body. It identifies pathology based on altered tissue metabolism. It measures energy requiring metabolic changes. When you go to the principle, you know that we have just seen that it's a branch of nuclear medicine. So you need a radioisotope or a radiotracer. A radioisotope or a radiotracer is given intravenously to the patient. The tracer gets incorporated into the cells. Malignant cells trap more of the tracer. So there is a small waiting period for the tracer to get concentrated in the malignant cells. This is called the assimilation time. When you give the radioisotope intravenously, the tracer gets incorporated into the cells. The malignant cells trap more of the tracer, so there is a waiting period for the tracer to get concentrated in the malignant cells, and this is called the assimilation time. Once it gets accumulated in the malignant cells, there is positron emission decay of the tracer. You choose such a tracer which will enable you to have a positron emission decay. Remember, the PET scan is positron emission tomography. So there is a positron emission decay of the tracer, beta pos decay. Beta plus is a symbol for positron. The positron after decay travels a short distance and collides with electron. Electron is beta minus, the antiparticle of positron. Remember, electron and protons are not antiparticles. Proton has a weight. It has an atomic weight. Whereas electrons and positrons do not have any weight. Electrons and positrons are antiparticles of each other. So the positron travels a short distance and collides with electron, beta minus, antiparticle. So there is an annihilation reaction due to this collision, and this results in two photons, gamma rays. The two photons move at opposite direction, 180 degree. So as the positron travels a short distance and collides with the electron, there is an annihilation reaction that results in two photons, gamma rays, which travel in opposite direction. The two photons are detected by opposing detectors. Computer assembles signals into images that represent radiotracer uptake in the body part scanned. So there is a radiotracer uptake, then there is a positron emission decay, positron collides with electron, there is an annihilation reaction, two photons are detected by the opposing detectors. Based on these detectors, computers assembles signals into images that represent radiotracer uptake in the body part scanned. So, we frequently integrate PET scan with the CT scan. The advantages of integrating the PET scan with CT scan are you have superior localizations. CT always gives you better bony and other anatomy, right? So integration of PET with CT gives you superior localization. It can distinguish between physiological and pathological better, because after a CT scan you have some idea where the pathology is. So now if you integrate it with PET, you know where physiological uptake is and where pathological uptake is. The difference is better. CT detects pulmonary metastases which are missed by PET scans. Radiation burden is equivalent to two CTs. You must remember that when you integrate PET with CT, you are adding an additional radiation burden to the already there PET scan. PET already has a radiation burden. When you integrate it with CT, the radiation burden is equivalent to two CTs. Usually CT is followed by the PET scan, and this integration allows you for having a higher level of accuracy. So remember it, better localization, distinguish physiological and pathological uptake, CT detects pulmonary mets better, which are usually missed by PET, radiation burden is more than just one CT, CT is followed by PET scan, usually this results in higher accuracy. Now when we move to the applications of PET scan in ENT, we are usually discussing the FDG PET, fluorodeoxyglucose PET. We will see what FDG is about. So the applications are mainly in evaluation and management of head and neck malignancies. First, squamous cell carcinoma. PET scan is used in primary disease for staging and delineation. It is used for detecting synchronous malignancies. It is used to detect recurrence or residual disease. PET scan can be used as a surveillance tool for patients with high risk of relapse. You routinely consider FDG PET or FDG PET CT 8 weeks or more after radiotherapy. It can also be used as a post-treatment neck assessment. So where do you use PET FDG in head and neck malignancy, especially in squamous cell carcinoma? 1. To stage and delineate the primary disease, to detect synchronous malignancies, to detect recurrence or residual disease. This can be used as a surveillance tool in patients in risk for relapse. You can routinely consider FDG PET 8 weeks or more after RT. It can be used as a post-treatment neck assessment. Second, you can use it to detect occult primary tumors. FDG PET detects more primary sites than other conventional techniques. In papillary and follicular thyroid cancer patients, after surgery, if they have elevated thyroglobulin and negative iodine 131 scan, you can do a PET scan in them and see if they still have any remnant thyroid tissue. Patients where resectability in doubt. In such patients, PET scan is really useful. Patients with indeterminate lung lesions which aren't accessible to percutaneous biopsy, such indeterminate lung lesions can be detected by PET. Post-treatment status of salivary gland tumors can also be checked by PET scan. If there is increased uptake, you might know that there is still some residual tissue left. Clinical suspicion of more disease than conventional assessment demonstrates. So if you suspect more disease extent than what your examination is supporting, then you can do a PET scan to confirm that. So the uses of FDG PET are in squamous cell carcinoma to detect occult primary tumors, in papillary and follicular thyroid cancer patients after their treatment, in patients where resectability is doubtful, patients with indeterminate lung lesions not accessible to biopsy percutaneously, post-treatment status of salivary gland cancers, clinical suspicion of more disease than what conventional assessment demonstrates. Now we need to see the different radiotracers used in PET scan. This is a purview of nuclear medicine and they use radiotracers. The most commonly used radiotracer is 2,18F fluoro 2-deoxy-D-glucose or 2-fluoro-2-deoxy-D-glucose FDG, fluorodeoxyglucose FDG, 2-fluoro-2-deoxy-D-glucose. It reflects glucose metabolism and detects cancer cells. 15OH2O. Remember, oxygen is usually 16, right? So you use a 15O tracer, radioisotope of oxygen. 15OH2O PET scan detects cerebral blood flow. This can be used prior to carotid artery resection in patients of head and neck carcinoma. You can use radio-labeled nitroimidazole compounds, fMISO and fetnim. These evaluate hypoxic areas in head and neck tumors. You can use copper ATSM to plan the radiotherapy. You can use 11-carbon radio-labeled thymidine and methionine to measure proliferative activity in head and neck tumors. So we have discussed 5 radiotracers: FDG for glucose metabolism and detect cancer cells, 15OH2O for detection of cerebral blood flow prior to carotid artery resection in patients with head and neck cancer, fMISO and fetnim, they are nitroimidazole compounds, evaluate hypoxic areas in head and neck tumors, copper ATSM, plan radiotherapy, 11-carbon radio-labeled thymidine and methionine, measure proliferation in head and neck tumors. There is a non-oncological use of PET scan. You can use 15OH2O and FDG PET to check stimulation of auditory cortex by cochlear implants. This is a non-oncological use of PET scan to check stimulation of auditory cortex by cochlear implants. Now we move to the limitations of PET scan. It is time consuming. There is a time for assimilation when you give a contrast agent till it gets accumulated in the malignant cells. There is poor structural resolution, so you frequently integrate it with CT scan. There is poor distinction between malignant and inflammatory lesions. There is poor distinction between histological types. False results when glucose metabolism is faulty. When there is inflammatory lesions, that also takes up excess glucose and shows metabolic activity. So there is poor distinction between malignant and inflammatory cells. Limitations are it's time consuming, time for the assimilation, poor structural resolution, poor distinction between malignant and inflammatory lesions, poor distinction between histological types, false results when glucose metabolism is faulty. Now this is a picture of a plain CT scan where there is a small node in the left area. You can see in the left neck area there is a small node, but it's not very obvious. Whereas in the PET scan, it is very much active. So you can easily remember that this is PET scan in relation to the other functional MRI picture. You see like this, that this is a radioactivity sort of a thing. It is very, bright and fluorescent looking. So it is something like radioactivity, and radioactivity is used in PET scan and not in functional MRI. So this way you can distinguish if you get 2 pictures, one of functional MRI and one of PET scan. And believe me guys, they keep all such pictures for your DNB OSCE. Thank you guys for patiently listening. We sincerely hope that you liked our instructional video on functional brain imaging. If you do, please like, share and comment on our YouTube channel. And it would be grateful if you subscribe to our YouTube channel. Thank you.